Hi, good evening, all. Good evening, Dr. Radhika. Today we are here for Year in Review 2023. Today's topic is about top papers in bacterial infections. We have here Dr. Radhika S. Polisetti, PharmD, FID SA, BCIDP, BCPS, AAHIVP, is an associate professor in the Department of Pharmacy Practice at Midwestern University, Chicago College of Pharmacy, and clinical specialist infectious diseases at Northwestern Medicine Central DuPage Hospital in Winfield, Isle. She graduated from the University of Kentucky College of Pharmacy in Lexington, KY, and went on to complete a PGY1 pharmacy practice and PGY2 infectious disease specialty residency at the University of Pittsburgh Medical Center in Pittsburgh, PA. Dr. Polishetti's primary area of focus for the past 15 years has been building and managing a comprehensive antibiotic stewardship program at her practice site. She works closely with the infectious disease department as the Northwestern System Antimicrobial and Diagnostic Committee in the development of guidelines and protocols to promote appropriate prescribing of antimicrobials. Dr. Polishetty teaches infectious diseases pharmacotherapy at the college and is also involved in precepting pharmacy students as well as PGY2 infectious disease residents at her site. Dr. Polishetty has been an active member of FORCE, ACCP Infectious Diseases PRN, ACCP HIV PRN, SIDP, and Board of Pharmacy Specialties, Infectious Diseases Council, and North Illinois Society of Health System Pharmacist, NISHP. She is passionate about promoting infectious disease research and antimicrobial stewardship as a clinician as well as an educator. Dr. Radhika, ma'am, the stage is yours. You can take over.
Thank you, Dr. Nishchara, for the kind introduction. I hope everybody can hear me okay. So I am really honored and excited to be here. Thank you for the organizers for including me in your year in review for 2023. So I am going to be covering top papers in bacterial infections that were published in 2023 that kind of had an impact on practice, at least in the United States. Okay, so this is kind of the learning objectives. We will review some of the papers that I picked. Obviously, in the interest of time, I tried to pick the ones that were the most relevant to clinical practice. We'll go through a few case scenarios as well, and then summarize some key points at the end. So these are the outline. This is the outline of the topics that we are going to review today. So this was a year of, I feel like, skin and soft tissue infection updates and new data for surgical prophylaxis. So I kind of included some of those studies here, but I also wanted to kind of give a preview of some new guidelines that might be coming your way for complicated urinary tract infections. We will spend some time talking about gram-negative resistance, and I am sure that is a topic that's relevant to practitioners here as well as in India. We will also talk about some other studies that were interesting, I thought, and some new antimicrobial agents that were FDA approved last year. Okay. With that, I will get started. I just wanted to mention that I was briefly a consultant for Gilead Pharmaceuticals during the COVID era, talking about having patients here with the disease, and but that in conflict of interest ended last year. Okay, so just to kind of orient ourselves with a case scenario. So per recent guidelines, what do you think is the latest recommendation for the duration of therapy for mild to moderate skin and soft tissue infections? And this is patients who do not have a bone involvement, so no osteomyelitis. And here are the options: 10, 7, 21, or 28 days. I would like you guys to think about this as we go through some literature update and then kind of answer this question on the other end. Okay, so like I said, like last year was the year of IDSA guideline updates, especially related to bone and joint infections, diabetic foot infections, and skin and soft tissue infections. So we will dive in and talk about the diabetic foot infection guidelines that were published in October of last year. So this was a consensus guidelines that was put together by an international working group of diabetic foot infection experts, as well as the Infectious Disease Society of America. As you may know, this is a huge disease burden. Across the world, we see a lot of patients in our clinical setting with out of uncontrolled diabetes, so which leads to chronic illnesses, chronic infections. When these patients present to our hospital, usually they are started on very broad spectrum therapy, usually including agents that have anti-pseudomonal coverage like piperacillin tazobactam or Zosyn or cefepime. And the reason for that is a lot of clinicians fear that by not covering these nosocomial pathogens, we are doing the patient a disservice because they're very complicated. So these patients end up receiving very broad spectrum therapy for a very long time. So the purpose of these guidelines was kind of give the clinicians a little bit of guidance in this age of antimicrobial resistance. Obviously, we do not want to give patients unnecessary broad spectrum therapy, especially for a long duration of time. So kind of the key takeaway from these guidelines that I felt like were very important and that I took back to our physician group at our hospital was do not treat clinically uninfected foot ulcers. And again, a lot of patients with uncontrolled diabetes may have chronic wounds, chronic ulcers, but the patient is clinically doing well. They are coming here for unrelated reasons. It is not an infection. If it's just if the wound just looks bad, but the patient is not exhibiting any signs and symptoms of infection, we recommend not to treat it. Also, the guidelines say that you should target aerobic gram-positive pathogens only, like beta hemolytic streptococci or Staph aureus, including MRSA, for mild diabetic foot infections. And again, these are patients who have not recently received antibiotic therapy and reside in North America or Europe. They also highlight to do not empirically target antibiotic therapy against Pseudomonas aeruginosa in cases except when the patient already has a culture growing Pseudomonas in the affected site within the last few weeks, or the patient is from another country, like in the United States. If the patient comes from Asia or North Africa, those patients are more likely to have resistant pathogens. So the guidelines say that you could empirically cover, but otherwise the anti-pseudomonal coverage should be reserved for patients who already have a previous culture. Okay, so regarding duration of therapy, also, like I previously stated, in clinical practice, these patients end up getting prolonged courses of antibiotic because of other comorbidities. The guidelines tried to consolidate the recommendations regarding duration of therapy as well. So, for example, you can see that for skin and soft tissue infection without osteomyelitis, the guidelines recommend 1 or 2 weeks of therapy. If the diabetic foot infection is extensive, resolving slower than expected, or if the patient has had or has had severe peripheral artery disease, then they recommend going longer, like 21 to 28 days. If there has been an amputation for diabetes-related osteomyelitis or there are positive bone margins, then they recommend duration of at least 3 weeks. And if there is no bone resection, but the patient has osteomyelitis, then the duration is 6 weeks. So again, you can see for mild to moderate, no bone involvement, you could probably get away with the 7-day course. But if there is bone involvement and there is no amputation, as in like line number 4, then the treatment duration duration becomes extended to up to 6 weeks. So going back to our clinical scenario, the most appropriate answer in this case would be 7 days. Again, because we are saying the patient doesn't have any bone involvement, no osteomyelitis. Okay, the other our study kind of that was in line with this study, but also was an IDSA update, was a summary of the periprosthetic joint infection. So for those of you who practice in a hospital that does a lot of surgical cases, arthroplasties and things like that, this might be of relevance to you. My hospital where I practice is a very big orthopedic surgery hospital. So this is something that these are the patients that we visit, like see a lot in our practice and make recommendations for. So this slide is actually from the executive summary itself, and it's kind of a visual representation of how there is shared decision making when it comes to patients when they have a very complicated surgical periprosthetic joint infection. So they're the orthopedic surgeon, the infectious disease physician, as well as the patient, and then also how long we treat and how we treat depends on several factors as listed here, such as what the organism is, how chronic the infection was, the health of the soft tissue and the bone stock, the comorbidity of the patient, and whether they're able to tolerate surgery, and the patient factors and preferences. So among the surgical management, there are two approaches that are usually taken. One is called the one-stage exchange, which is also known as DARE, which is debridement, antibiotics, and implant retention. So what that means is in one stage, the surgeon will give a patient a course of IV antibiotics, will do the debridement, give them IV antibiotics, and then give them oral antibiotics with or without long-term suppression. However, in a two-stage exchange, when there is a periprosthetic joint infection, first there is the joint replacement or the surgery, and then after the surgery, the infection has resolved, then the surgeon implants the new device, the new hip or the knee, and both these steps are kind of followed by IV antibiotics and oral antibiotics. Usually fluoroquinolones and TMP sulfa or Bactrim are the antibiotics that are most commonly used for this type of infections. They have the most data because of a superior bone penetration. But at least in the United States, there's a lot of resistance creeping up for fluoroquinolones, as well as a lot of side effects. So we have started using beta-lactams and some other antibiotics as well for the long-term therapy. But again, the duration of these procedures, the duration of antibiotics can be anywhere from 2 to 4 weeks, sometimes as long as 6 weeks. It really depends on the patient and how they're tolerating the procedure and if all the infected tissue was removed. Okay, and then to round up the surgical prophylaxis topic, there was a study that was relevant again, which was a trial of vancomycin and cefazolin as surgical prophylaxis in arthroplasty. And why this study was important was that if you look at the IDSA guidelines for surgical prophylaxis, they recommend adding vancomycin to a beta-lactam like cefazolin if you reside in an area which has a greater than 20% MRSA rate, which pretty much the entire United States does. Where we live in Chicagoland, the MRSA rates in our community are anywhere between 30 to 35%. So our orthopedic surgeons will routinely add vancomycin whenever they are doing hip or knee arthroplasties. So the question was, is that even necessary? So this was a multi-center, double-blind superiority placebo-controlled trial. So as far as trials go, it was a very well organized study. the patients, so what they did was they randomized patients who had no known MRSA colonization, who were undergoing arthroplasty, whether it was hip, knee, or shoulder. And these patients were randomized to receive either vancomycin or normal saline placebo in addition to cefazolin as prophylaxis. And the primary outcome was the presence of surgical site infections within 90 days of surgery. So all the patients got cefazolin, but they were randomized to either receive an additional vancomycin versus a placebo if they, met criteria. So 4,200 patients underwent randomization, and you can see over 4,000 patients in the modified intention to treat population basically were included in this study results. Most of the patients were, you can see, knee surgery patients. There were some hip arthroplasty as well, and minority of them were undergoing shoulder arthroplasty. So 91 of them, or 4.5%, in the vancomycin group, and 72 patients out of the 2,000 patients in the placebo group had a surgical site infection. And in the patients undergoing knee arthroplasty, the rates were 5.7% in the vanco group versus 3.7% in the placebo group. So the adverse effects were kind of similar between both the groups. So both the groups had about 1.7% rate of adverse drug reactions. So what this study showed was there was really no benefit of adding vancomycin to cefazolin if the patient does not have known MRSA colonization. And just kind of, its practical application, we did have a protocol where we were routinely doing MRSA screens for our patients before orthopedic surgery, but that was causing some delays and there were some operational issues with it. So we kind of, started routinely giving everybody vancomycin. So it's kind of like, we have data, but then there's also real world constraints. So again, this is a discussion that we are having on an ongoing basis with our surgeons to see if we could implement this in practice. Okay, switching gears to something new and exciting that was presented at ID Week last year, during the ID Week International Conference in Boston. There is a new clinical practice guidelines for the treatment of complicated urinary tract infection that is going to be released soon. And these are the first ever IDSA guidelines on this topic. So it's very interesting. And so I just wanted to go through some key features because I know most of you in your clinical practice must be taking care of patients with complicated urinary tract infections. That's one of the most common diagnoses of patients who are admitted to our hospital. So you can see here on the left side of the screen, the old definition of uncomplicated urinary tract infection was basically anybody, who has an acute cystitis in a healthy, non-pregnant, afebrile woman with no diabetes or no urological abnormalities. Everybody else kind of fell in the complicated category. But the new definition, basically, it puts the onus on the clinical presentation of the patient. So we are defining the new complicated urinary tract infections as patients who has infections that are beyond the bladder. So pyelonephritis, catheter-associated UTIs, febrile or bacteremic urinary tract infections. These are complicated, and uncomplicated is basically everything else. And now you can see men and women they both can have uncomplicated UTIs, which was not the case before. And as far as the choice of empiric therapy goes, the guidelines pretty much say that there is no like right or wrong answer. You really have to look at different criteria before making the determination as to what the patient needs. So severity of illness, risk factors for resistance, patient-specific considerations. If the patient is septic, look at the local antibiogram and use broader therapy. So they kind of break it down by condition of the patient, sepsis or without sepsis, and then they may ask you to choose appropriate agent based on your local resistance patterns and your local antibiogram. So what they have found is that you do not have to give somebody who is coming in with a complicated UTI, but they do not have sepsis, you do not have to give them an anti-pseudomonal agent if there is, if you're residing in an area where the patient, will be fine without it. So you could get away with a third or fourth generation cephalosporin. Okay, so again, this kind of summarizes what I was speaking about in the previous trial, and they kind of go into detail as to how you would evaluate if the patient has sepsis. So, if they have, if the patient is hemodynamically stable, source control has been achieved, you have kind of relieved any obstruction, there's no further procedures, then you could go down this algorithm and treat for a short course. Obviously, if the source control has not been achieved, then you would have to reassess the UTI and plan for a longer course. So again, the big difference here is they really want you to evaluate each patient on an individual level and kind of make the determination whether they need broad spectrum therapy, whether they meet the criteria for sepsis, and if they do, then you would choose an agent that has greater than 90% susceptibility per your hospital antibiogram. One caveat here before we apply the new guidelines is that they did exclude patients who have indwelling urinary catheters, severe sepsis, immunocompromised patients, and bacterial prostatitis, patients with functional and structural abnormalities, as well as the duration. They did mention that it's not very clear for men who have known or likely prostatitis. And again, you can see these are more complicated patients. They have lack of source control. So obviously, these are the patients that we would have to take as a case-by-case basis, but may warrant longer therapies. Okay, so moving ahead to another case scenario, just to kind of assess our own understanding of what we have learned. A 67-year-old patient is admitted to your hospital for a catheter-associated urinary tract infection. He has no history of MDR pathogens, and his most recent past culture shows a pan-susceptible, which means it was susceptible to all the antibiotics tested. However, the urine culture that was just collected in the emergency room is now growing Enterobacter cloacae, and the susceptibilities are pending. What is the best empiric option for this antibiotic for this patient, and how would you proceed? So these are your options. So levofloxacin, which is a quinolone, aztreonam, cefazolin, or ampicillin. And we will kind of think about this question as we go through and talk about the 2023 guidance for antimicrobial resistance. Sorry, I'll go back. So the answer in this case would be levofloxacin, and we will talk about why that is the most appropriate option. So one of the other big practice changing or kind of important papers that were published, and they were building off of something that the Infectious Disease Society of America started doing in 2022, was updating the guidance for treatment of resistant gram-negative infections. So this is basically a group of experts, including a clinical pharmacist with specialization in infectious disease, a lot of ID physicians, who put together this document because, again, we are facing a lot of gram-negative resistance, and a lot of clinicians are struggling with what would be the most important, what would be the best option for their patient. So I will go through what the IDSA guidelines recommended, but I also wanted to show you kind of the summary recommendations to kind of make it relevant for your clinical practice. And all this information actually is on our Northwestern Medicine Antimicrobial Diagnostic and Stewardship Committee website, which is a public-facing website. It's free to use for everybody. So I would really encourage you to go there if you need more information or want to look at any of our protocols or guidances. So again, for treatment of AMP-C producing Enterobacterialis, so for those of you who went to pharmacy school a few years ago, we were taught that, the space organisms or the spice organisms require special treatment. So the space organisms are in organisms like Serratia, Pseudomonas, Acinetobacter, Citrobacter, and Enterobacter. And the reason behind this was they were supposed to be producing the higher producers of AMP-C, which is a beta-lactamase that can break down the first-generation penicillins and even some first-generation cephalosporins. But the new data actually shows that not all of the space or spice organisms are AMP-C producers. Some of them are weak producers, so we really do not need to escalate therapy every time we see, a Serratia, for example. So now I would, kind of say that out with space and in with heck yes, which is the acronym for these organisms that are listed here on the right side of your screen in green. Those are the pathogens. If we see those come back in a patient's culture, and they are on a first generation cephalosporin, we would recommend escalating therapy to something that would cover an AMP-C producer. So they include Hafnia albi, Enterobacter cloacae, Citrobacter frundi, Klebsiella aerogenes, and Yersinia enterocolita. And then again, we further break it down by either, if the patient has uncomplicated cystitis with one of these agents, we could probably get away with oral therapy like nitrofurantoin, TMP sulfa, ciprofloxacin, levofloxacin, or a single dose of an aminoglycoside. And if it's a severe or more complicated infection, we would escalate to a fourth generation cephalosporin like cefepime or meropenem. For uncomplicated cystitis, there's some data that ceftriaxone may work as well because of the concentration it achieves, but again, it is a second line option. Similarly, there is updated guidance for the treatment of Acinetobacter baumannii, which is another pathogen that is frequently shown to have very, more resistant kind of capabilities. So the empiric guideline recommendation, I think the biggest thing here is to understand which patient is colonized versus which patient is actually infected. So for example, we do see several patients admitted in our ICU who may have had a previous history of a lung transplant, who are otherwise stable, and sometimes, the bronch or the BAL will show Acinetobacter grow out, but the patient doesn't have any respiratory symptoms, no clinical signs, they do not have increased production, like sputum production, there's no increased secretions. So in that case, the clinician may decide to hold therapy for now, and it could be just a case of a colonization. However, in a patient that is exhibiting signs and symptoms of a infection like, fevers, chills, increased sputum production, increased secretions, rigors and things like that, the first line option is usually ampicillin sulbactam. Most of our Acinetobacter, thankfully, is actually susceptible, at least in the hospital that I practice in, is susceptible to ampicillin sulbactam, but sometimes we do see carbapenem resistant versions, which is also frequently known as crab. If there is that, if it is a crab, then we usually will add a second line agent like aminocycline, or there's a new agent which we'll talk about shortly, the durlobactam, sulbactam, and then there is a couple of other agents also like cefiderocol or polymyxin that can be added for, that can be added for complicated patient. So again, the treatment of crab really depends on how the patient is presenting. If it's a colonization, mild to moderate infection versus moderate to severe, but usually the first line is always high dose ampicillin sulbactam, which we give as an extended infusion. And IV minocycline is the second agent that we usually add. Okay. The other commonly encountered gram-negative resistant pathogen is CRE, or carbapenem-resistant Enterobacterales. I'm sure you guys have probably seen a lot of these patients in your practice. It is something that we see very commonly now, even in our community patients who are coming from a nursing home, long-term care facilities, patients who have had repeated rounds of IV antibiotics are more likely to come up with, resistant pathogens like this. So if a patient grows out a positive carbapenemase producing organism, whether it's a New Delhi metallobeta-lactamase, a WIMP, IMP, or a KPC, or if the patient is critically ill but had a CRE in the last few years, last few cultures, we will empirically cover those resistant genes. Most of these antibiotics that are listed here, like ceftazidime avibactam or meropenem vaporobactam, at least in our institution, are restricted to an infectious disease consult, again, because these are newer broad spectrum agents. So we want to make sure that the patient is evaluated correctly before using it. But you can see in the top of the slide here, the patients who have an uncomplicated cystitis with these pathogens, we could still get away with some of the oral antibiotics if they are susceptible. But once we see more complicated resistance markers, or the patient is more, sicker, they are in the ICU, then we reserve and we go to these novel beta-lactam, beta-lactamase combinations that have been approved in the United States in the last few years. So if it is a KPC producing organism, which is a Klebsiella carbapenemase, we usually prefer to use a meropenem vaporobactam or ceftaz-avi. If it's an NDM or a WIM or IMP resistance marker is seen, then we will use ceftaz-avi in combination with estrionam. And if it's an oxa-like resistance, then we will use avicaz or ceftaz-avibactam. And the second line agents are listed here as well. Cefiderocol is a new cephalosporin antibiotic with a very novel mechanism of action that was approved a couple of years ago. And we have it on formulary as a last line option for a very critically ill, sick patient. But again, these are patients that need infectious disease evaluation. Okay, and then moving on to ESBL producing organisms, as you guys have probably encountered too. These are pathogens that exhibit the CTXM gene on molecular tests, so they are resistant to the first and second generation cephalosporins. In uncomplicated patients, we could use some oral options like nitrofurantoin, TMP sulfa, Cipro, or levofloxacin. However, if the patient is complicated in any way, or they have a complicated UTI or, a pneumonia or a bloodstream infection, based on the studies that have been published, like the Marino study, I would highly encourage you to go to a carbapenem, because studies have shown that piptazo is inferior to meropenem in that situation. So for a complicated patients, we would definitely escalate to a meropenem. And last but not the least, we cannot, end our resistant organism topic without talking about Pseudomonas. So multi-drug resistant Pseudomonas is an organism that is showing non-susceptibility to at least 3 of the following drug classes: penicillins, cephalosporins, fluoroquinolones, aminoglycosides, or carbapenems. And there are some, thankfully, we have new beta-lactam, beta-lactamase combinations that we can use. I remember the time where we were stuck with using polymyxin B or colistin. And very toxic regimens for this agent, because we just did not have any options available. So now we do have Zerbexa or ceftolozone tazobactam, which can be used, or a single dose aminoglycoside. And then this agent works pretty well for MDR Pseudomonas, but we also have ceftazidime avibactam for those organisms that are resistant in this situation. Okay. All right. So that was kind of a review of gram-negative resistance and what agents you would use if you had a patient that comes into your hospital with those infections. So just to kind of wrap up with patient case. This is a 75-year-old female with a past medical history significant for hypertension and COPD, and she's admitted to the intensive care unit with respiratory failure. The patient is hypoxic and started on supplemental oxygen. Her admission blood cultures is growing GPCs in pairs and chains, but the BCID technology also identifies that there's E. coli in the blood culture, and the resistance marker detected shows that it is exhibiting the CTXM gene marker. So based on that, what would you do given that the patient is doing well clinically and is stable? So I'll give you guys a second to think about it. But basically, based on our discussion, if this is a CTXM producing E. coli, then I would definitely escalate to a carbapenem, because this patient is in the ICU and she is hypoxic and she is, showing signs and symptoms of a pneumonia, and if the blood culture is positive, we would not need cefiderocol right off the bat, just because the patient has not failed meropenem, but that's definitely an option. And I don't think we need to keep Vanco for the most part. Even if this patient had strep in their blood along with the E. coli, we would be able to target both using a meropenem. All right. So switching gears, I wanted to wrap up with some other clinically relevant studies and important papers that kind of made the top papers of 2023 for last year, which were interesting from a clinician point of view. So one of these was the incidence of colorectal cancer in patients who are diagnosed with pyogenic liver abscess. And again, a lot of these studies have shown these associations from Asia, but this was the first time that this was a very big study that was done in the United States that actually showed this correlation. So that was very interesting to see. So this was a patient-level matched retrospective cohort study conducted in 127 Veteran Affairs hospitals across the US between 2003 to 2020. The primary endpoint was to investigate if there was an association between a pyogenic liver abscess and a subsequent diagnosis of CRC, which is colorectal cancer. So they actually had a very robust a number of patients that were enrolled in the study. So they had over 8,000 patients who were diagnosed with a pyogenic liver abscess, and they picked 23,000 patients who were matched cohorts to kind of compare them to. And both the groups were very evenly matched. This is the veteran affairs. So most of it, over 90% of the patients were male. Most of them were over 60 years old. Both the groups were very evenly matched. And they found that the incidence of colorectal cancer was significantly higher in a patient who has been diagnosed with a pyogenic liver abscess compared to the control. And it was especially high in the first 6 months. So the incidence was high in the first 3 years, but the incidence was like fourfold in the first 6 months of diagnosing a pyogenic liver abscess. So, and interestingly, there was no difference based on what pathogen the patient grew, or if the liver abscess happened because they had a history of cholangitis or cholecystitis. So what this data shows is that if a patient has a pyogenic liver abscess, they really need to be screened very aggressively and very frequently for colorectal cancer, especially in the first few years right after the liver abscess, because that's where the correlation happened the most. Okay. So I thought that was an interesting, correlation that they found in such a big patient population. So just to kind of review some new antimicrobial agents that were approved last year that you may see in your clinical practice. So there's some of the new agents that are listed here. So what pathogen does the newly FDA-approved antibiotic sulbactam, durlobactam, or Zacturo have activity against? So the options are Pseudomonas, aeruginosa, CRE, carbapenem-resistant Klebnemo, Acinetobacter baumannii, or Stenotrophomonas multifilia. So the answer here is the Acinetobacter, and we will talk a little bit about this new agent. So sulbactam, durlobactam, or Zacturo was approved in May of 2023 last year. It has an FDA-approved indication for hospital-acquired bacterial pneumonia and ventilator-associated bacterial pneumonia caused by Acinetobacter calcotis complex susceptible isolate. The mechanism of action, again, this sulbactam, as we all know, is a beta-lactam antibacterial and Ambler class A serine beta-lactamase inhibitor. It works by inhibiting penicillin binding proteins 1A, 1B, and 3 within Acinetobacter baumannii. Durlobactam is a new novel agent, and it is also a beta-lactamase inhibitor. It actually by itself lacks activity against Acinetobacter baumannii complex, which is interesting. But when it was combined with sulbactam, it actually provides protection from degradation by inhibiting class A, C, and D beta-lactamases. So it can lower the MIC of sulbactam by 32-fold. So that's pretty interesting because, a drug that is by itself not active against the ABC pathogen is active when it is combined with sulbactam. So because of that, it achieved its FDA approval. Like I said, Acinetobacter baumannii are pretty problematic pathogens in our academic medical centers. We do see outbreaks of them in our medical ICU or our cardiothoracic ICU, especially in lung transplant patients or immunocompromised patients. So this is, again, a good, tool to have as an option. We kind of talked about the treatment of CRAB earlier and how, amsulbactam is usually our first-line agent. But before this drug was approved, we used to combine high-dose amsulbactam with either polymyxin B or tigecycline based on the source of the infection to uncover the pathogen, but now this agent has kind of become the second line option so that we can spare the patient toxic regimens like polymyxin B, antigacycline also, which is not as effective as the beta-lactamase combination. And I have some details here. Obviously, which patient, the combinations have efficacy in certain patient populations. So we kind of reserve these newer agents when we have exhausted other regimens, and also the patient's MIC is less than 4 microgram per ml. And again, these are recommendations from the antimicrobial resistance guidance from the IDSA. All right. And then just to kind of highlight another another gram-positive drug that was approved for last year was ceftobiprole for the treatment of Staph aureus bacteremia. So again, Staph aureus bacteremia is the bacterial infection that we are always worried about because Staph aureus is very highly pathogenic, as well as it can cause a lot of resistance. We also see patients who fail therapy. They have recurrent infections. It's very hard to clear. So anytime we have a new agent that can target Staph aureus, we are always excited for it because we feel like we are going to be able to use it in our clinical practice. So just looking at the data behind this agent, so ceftobiprole is a cephalosporin antibiotic that was evaluated for treating complicated Staph aureus bacteremia, including methicillin-resistant Staph aureus or MRSA. This was a phase 3 double-blind, double-dummy, non-inferiority trial. The patients were randomized to receive in a 1:1 ratio to either get ceftobiprole at a dose of 500 milligrams intravenously every 6 hours for 8 days, and then every 8 hours after that, or daptomycin at a dose of 6 to 10 milligrams per kilogram every 24 hours. And the physicians also had an option of adding aztreonam to either of these arms if needed. The primary outcome was overall treatment success at 70 days after randomization. So I thought that was good. They did follow people beyond the 30-day mark. And they defined success as survival, bacteremia clearance, symptom improvement, and no new Staph aureus bacteremia-related complications. So I think they had a pretty robust, definition of what treatment success looks like, and the safety of the antibiotics were also assessed. So of the 390 patients who underwent randomization, 189 were in the ceftobiprole group and 198 were in the daptomycin group. These patients had confirmed Staph aureus bacteremia and received ceftobiprole or daptomycin. And you can see that the success rate was pretty similar in both groups. So 69.8% of the patients in the ceftobiprole group versus 68.7% patients in the daptomycin group had an overall treatment success. So the study concluded that that ceftobiprole was non-inferior to daptomycin with respect to overall treatment success in patients with complicated Staph aureus bacteremia. However, when you dive deeper into the study, there are a couple of caveats to keep in mind. Most of the patients, even though they had Staph aureus bacteremia, they actually had MSSA or methicillin susceptible bacteremia, not MRSA. So that is kind of interesting because obviously if it is MSSA, most of us would use a beta-lactam to treat the patient. We wouldn't use something like ceftobiprole or even daptomycin for these patients. Also, the trial did not have enough power to do the subgroup analysis. So they had whatever few MRSA patients they had, they were not powered to detect difference for those patients. So I feel like if you are going to use this drug for MRSA bacteremia, we may need a little bit more data to support its use. But definitely a good option if you don't have any other option for complicated staph bacteremia. Okay. And then one of the studies that kind of made a lot of, waves in the United States last year because of its unique study design was called the ACORN study, which was published in JAMA. And I just wanted to add this into our discussion just because you might be seeing a lot of studies kind of being organized this way because, infectious disease research is very hard to do and outcomes research is very hard to do because, it's not unlike a cardiovascular study where we can enroll thousands and thousands of patients in a short duration of time. Some of the infections patients, it's very hard. It takes a while to get enough N or enough number of patients to actually reach power. So it's very hard to do that research. So this was a unique study. So what they did was they were trying to answer this clinical question that has been a clinical controversy for years now, which is whether the choice of cefepime versus piperacillin tazobactam affects the risk of acute kidney injury or neurological dysfunction in adults hospitalized with acute infection. And what they looked at, the study population was about 1,400 men and 1,000 women, and they were hospitalized with acute infection. The median age was 58 years of age. And this was done again at a single center in Nashville, Tennessee. And the intervention was basically 2,600 patients were randomized, about 2,500 were analyzed, half of them got cefepime, and then the other half got piptazo. And the primary outcome was highest stage of acute kidney injury or death by day 14, measured on a 5-level ordinal scale. So it ranged from no acute kidney injury to death. And what they found was the highest stage of acute kidney injury or death by day 14 was very similar between the two groups. So if you can see in the cefepime arm as well as the piptazo arm, it was 7%, in the cefepime arm, 7.5. So there was no significant difference between the groups. The odds ratio was 0.95. So they concluded that it really doesn't matter. One antibiotic isn't like more nephrotoxic than the other for these, critically ill patients that are coming into our hospital. However, there are some limitations and caveats to keep in mind before we kind of throw the book at this and say, okay, we are done. We have answered this question. So this study, the patients had this is an ongoing debate. However, they kind of concluded that there's no association between AKI or death by day 14, despite the fact that 75% of the population received concomitant vancomycin. And as we all know, vancomycin does have a propensity to cause some acute kidney injury. It can cause elevations in serum creatinine. So it's kind of hard to determine if, they did the due diligence to see if, the differences were just kind of hidden because both the groups got vancomycin. Also, there was a concern that they use serum creatinine as a marker for AKI, and that can be sometimes unreliable, especially in patients who are septic or critically ill. Also, there was an imbalance in the baseline characteristics of the patients in the two arms. So there were more patients in the cefepime arm that were diagnosed with sepsis than the piptazo arm. And we don't know if that could have impacted the way the drug was cleared and, kind of made the piptazo arm look a little bit better by comparison. So definitely further studies are needed. Also, the duration of treatment for these patients was not very long. I think they evaluated patients who got the dose for like 48 hours or 72 hours, but a lot of our patients received antibiotics for a lot longer than that. So the questions are still there. However, this trial was lauded for the having a unique design, because that is something that we could replicate to answer questions. So what they did was the recruitment was done via the electronic medical records, or the EMR, and they had like a screening protocol that was embedded in Epic when the patient is actually admitted, and the physician could actually enroll the patient while they were putting in orders, which was something very unique about this study. So you will hear a lot more about this trial design in infectious disease research in the coming years, I think, because it can show us, clinically relevant outcomes quickly. It has increased external validity, and it had very broad inclusion and exclusion criteria. And just to kind of show you how the screenshot looked like in Epic, and this was published in the British Medical Journal as well, because again, very interesting trial design. So you can see that the physician basically got this alert saying that the patient is eligible for this study. These are the inclusion and exclusion criteria. Would you like to change any orders, right? And they had like an order set embedded. Again, they could choose like what they want to do, what the reason is, what patient, if the patient, meets any inclusion or exclusion criteria, and accept. So again, makes it easier for us to do clinical research. So more to come on that, but definitely a first step towards, answering the question of whether combination with piptazo versus cefepime makes a difference. Okay. And then I just wanted to wrap up in the last few minutes talking a little bit about top two topics that you may have heard about already in some of the other discussions you may be having, but it's definitely, no bacterial infection topic or treatment topic is complete without talking about penicillin allergy, at least in the United States, where we have about 10% of our population that reports having a penicillin allergy. So it creates a big burden on clinicians when they are, admitted to the hospital. So this was the paper that I thought was very irrelevant if you have patients who are basically admitted and they have a penicillin allergy, reported. I also wanted to throw in some references from previous years, not strictly 2023, but the penicillin allergy debate and updates have been going on for the last few years. And I feel like we are building on to this information. So I just wanted to put everything together into, just to kind of have it complete for you guys as a reference. So like I said, about 10% of the United States population has a penicillin allergy, but according to the CDC, less than 1% is truly allergic to penicillins. And 80% of the patients who have an IgE-mediated reaction do not have a reaction after 10 years. So again, the reason why this is a huge healthcare burden is because having an allergy has been shown to have higher rates of treatment failure, adverse effects like C. diff, VRE, resistant pathogens like VRE and MRSA, and longer hospital stay. Again, what we use in our practical hospital setting to evaluate patients is we have a guidance document to basically interview and delabel patients as needed for penicillin allergy. So our pharmacists will look at what their previous allergy was, and especially if it's a surgical patient, they'll look at the side chain chart that is on our Northwestern website. And if the patient does not have any common side chains with the antibiotic they are prescribed, we will allow the patient to receive that antibiotic. And as you can see, cefazolin, which is one of the most common agents that we use in our hospital, does not have any side chain similarities with any of the other beta-lactams. So definitely a safe choice for most of the patients, even if they have a mild to moderate reaction like rash or hives. Okay, and then just to summarize what you would do with these allergies, there was a paper that was published in late 2022 that kind of summarized like how you would approach these patients. And this is kind of what the new guidance of delabeling kind of built off of. So if a patient has a low risk of, allergies, symptoms like GI symptoms, you could do a direct amoxicillin challenge. If they had a moderate risk, you could do a skin testing. And if they have a high risk, then definitely get an allergy consult and go from there. And then last but not the least, this is not strictly an antibiotic or bacterial topic, but this was a very hot topic in the United States in the last few months. I just wanted to add this in because this is, again, something we see. We have a pediatric hospital attached to our hospital, and we have patients who come in our infants as well as in our elderly patients during the flu season. We do see several patients come in with the RSV infections. And so I just wanted to kind of hone in on giving you an update that there is now not only an immunoglobulin that can be used for the treatment of RSV in infants, but now we have vaccines that are recommended. And these are the Renoir trial, the Matisse trial, as well as the Melody trial. They all kind of built off of each other, where they showed efficacy of a vaccine in preventing RSV-associated illness in older adults, as well as efficacy against children of vaccinated mothers. And for patients who have, children who are admitted with RSV, we have now immunoglobulin. The nirsevimab is also available, a monoclonal antibody that can be used. And these are the updates from the CDC on this topic. And in the interest of time, I will wrap up with the summary. So as you guys probably have seen in your practice, there have been several new guidances and guidelines that have been published in 2023 that are relevant to our clinical practice. In treatment of bacterial infections, as well as promoting antimicrobial resistance. We have new options for the treatment of multi-drug resistant organisms, such as, Durlobactam, Sulbactam, Ceftobiprole, and others. And clinical pharmacists, I think, across the world are playing a very important, crucial role as members of healthcare team. And we are involved in appropriate selection, dosing, duration, and monitoring of antimicrobial agents to ensure a positive outcome for the patient and to prevent adverse reactions as well as emergence of antimicrobial resistance. So with that, I will end my talk and hand it back to Dr. Nischala, and I'm happy to answer any questions that you may have. And again, thank you guys for having me. Really an honor and a pleasure to be here with everybody today.
Thank you so much, Dr. Radhika. That was an insightful presentation about the top ID papers. Thank you so much. So now let us take a few questions that they've posted. The first question would be, is there any updated guidance on empiric therapy on diabetic foot infection?
So there is a paper by Dr. Penfield Cortez, who is one of the ID physicians. So apart from the infectious disease guidance, I think the paper that I mentioned before in the beginning, let me just go back to that. That should give you empiric therapy. Options. So this is, I would think that this would be a good place to start. But then there are also some other comprehensive guideline documents for the management of diabetic foot infections that was written by some of the clinicians in the United States, and I could send that reference as well. But definitely this would be the place that I would look for first. I think they have all the antibiotics and the evaluation criteria listed.
Okay. And coming to the second question, uh, do we need to always adopt to the guidelines, or how is the usual way of translating the guidelines to practice?
That's a great question. So guidelines are, guidelines. So they kind of are, when the Infectious Disease Society of America or the European, medical associations publish these, they are looking at evaluating the literature in the area, but they also give us a lot of options because they don't know where you will be practicing, right? So what our role as clinical pharmacists is actually looking at the guidelines and then kind of looking at the guidelines and kind of filtering out the information that is relevant to your patient population. So for example, when we look at the IDSA guidelines, for example, for UTIs or skin and soft tissue infections, what I'm looking for is what patient population should I be worried about the most? And then I would take those sections of the guidelines and the data that's behind, that's, active for that section and kind of use that. So you have to know whatever paper you are reading, you have to look at the inclusion and exclusion criteria for, very carefully and see if that applies to where you're practicing. For example, if the patient population, you work in a women's hospital, but all the data for a particular drug was in, male patients, then, you kind of have to see if that data translates to your patient population or not. So that's something that I think as clinical pharmacists, we are uniquely qualified to do, because obviously there are some studies where, you could apply international documents or international guidelines to your infection. So for example, multi-drug resistant Pseudomonas is probably say the similar across, different areas and, as long as you are meeting the same resistance markers, but your patient might be different. Their history might be different. So what drug you choose will depend on where you practice, what's on your formulary, what your local antibiogram shows, and things like that. And I think that's a shared decision making between the clinical pharmacist, the physician, as well as the patient. I hope that answers that question.
Yeah, thank you. Thank you for the answer. Coming to the last question, that is on antibiotic allergies. So,
Mhm.
how can we tackle escalation of antibiotic in view of suspected beta-lactam allergy, provided that the allergy can be falsely reported incident? So, what are your thoughts on beta-lactam allergy testing?
That's a great question. So, what we have started doing is, as you mentioned correctly, there's a lot of misreporting in terms of allergy, right? A lot of patients may not understand that, having a GI upset or something, or a migraine with an antibiotic is not a true allergy. At the same time, they may be told that they have an allergy when they were a child from their parent. And we do see patients who are in their 70s now who will say that I have a penicillin allergy. My mother told me that when I was 5, I had a rash with amoxicillin. So in those patients, what we try to do is we look at their history to see if in the last few years they have received a beta-lactam antibiotic. And a lot of times we do find that they have gotten an amoxicillin or something like that for a sinus infection or or other types of infection. And if that's the case, we will just remove the label from the chart. But if it's not as clear or the patient has never had a beta-lactam before, we ask the patient what they remember as their reaction. So for a patient who has had a very long distant allergy, like, they're older and now they had a reaction when they were a child, the guidelines right now recommend that you could do a direct challenge. So you could give the patient a beta-lactam, amoxicillin or a cephalexin, and and see how they do, because the incidence of having a reaction after a decade of not having a reaction are pretty low. The other option is if the patient reports having a severe allergy, like they said, oh, I had hives, but it was a while ago, but you need to give them this antibiotic. You could do a penicillin skin testing to see if they are truly allergic. For that requires either an allergist to be on call, or we have certain hospitals in the United States have a pharmacy driven protocol where the pharmacist can actually do a skin testing as well. So that's an option. So you could do a direct antibiotic challenge, you could do a skin testing, and the third and that approach that we reserve for our very critically ill patients are patients who will get a desensitization, which is done in the intensive care unit. So for an example of this is a pregnant patient who's coming in with neurosyphilis. We have penicillin is the only option that we have to give to the patient. If they have a severe allergy to penicillin, we will admit them into the ICU. The allergist will do a desensitization, but I think 80 to 90% of the patient, we are able to do a direct challenge or a skin testing to kind of, evaluate if the allergy is true, and then kind of delabel them or give them, appropriate therapy based on that.
Thank you so much, Dr. Radhika. That was a clear explanation that we have got for all the questions. Thank you so much.
Thank you very much for your time.